Welcome to the Cyber Health Podcast. I'm Stephen Perano, your host, and we are excited for this episode. Today in the studio, we have Dr. Omar Llaguna. He is a surgical oncologist. He specializes in GI malignancies. Welcome to the podcast.
Thank you for having me.
All right. So, Doc, it's been a while since I've seen you.
Yeah, it's been a bit.
Right? It's been a bit. I've seen you on the schedule at regional, but I'm mainly in doing thoracic vascular. So I unfortunately haven't run into you in a while. But it was always a pleasure to work with you, and thank you for taking time to come here to the studio and share your story. So for those of people that are watching that are not familiar with your specialty, can you explain a little bit about it?
Sure. So I'm a surgical oncologist. That means that I'm a surgeon that specializes in the treatment of cancers. In my specialty, for the most part, GI tumors, so liver, stomach, colorectal, small intestine, pancreas, and also skin cancers like melanoma.
Oh, wow. Okay. So very serious surgery. So some people I spoke to before we had this meeting today, they said that some people consider you Dr. Hope. and people come to you really on for hope, to save their life and to help them get through some very difficult times that they experience. How do you take that responsibility?
I think it's what I signed up for. I remember during my surgical oncology fellowship, I sat at tumor board. And I remember them presenting all these cases that are really complex with patients with advanced disease, and there's someone who had a primary tumor in the colon but had spread here, had spread there. And at that point I was very naive, and I just couldn't see the light of how are we going to improve this patient's quality of life, how are we going to help them live longer with an operation. And then slowly I learned that through a lot of multidisciplinary discussions of combining therapies of chemotherapy, radiation therapy, and different follow-ups. We were able to somehow massage the situation to try to get the patient to an operation with the hope of either a cure or at least palliating their symptoms.
Wow, okay. Yeah. Now, we will bounce around this in this episode a little bit. I do want to start off with where you're from. What's your background?
So I was born in New York, both Cuban parents who were immigrants. Lived in New York till I was about 12 years old. Moved to Miami to start high school in LaSalle High School in Coconut Grove. And then I've been here pretty much ever since.
Nice, yeah. Nice. Now, can you share, if you recall, the time that you met Jeremy Eckstein in New York?
Oh, yeah. I remember that. So, Jeremy and I, we're 1 year apart in our training. He was the second year, I was an intern. And it was actually my first call. And it was 4th of July weekend, which, interns begin in July. July 1st is the first day of residency. So I'm like fresh out of medical school. And it must have been like 4 o'clock in the morning. And I just got a call about a patient who had high blood pressure. And I was like, oh, I have no idea. And I just remember turning to Jeremy and asking, like, dude, what do I do? Would I have high blood pressure, right? He told me, gave him a bit. I forgot what he told me. But whatever it was, I was like, oh, my God, this is so genius. And I called the nurse back. And that was our first interaction. And then from then on, we just kind of stayed friends and worked a lot together and just stayed very close throughout the years.
Now, did you participate in any of his music ventures?
No, I've seen the videos, but I haven't.
No, okay. Well, we had him here not too long ago, and he spoke nothing but highly of you.
Oh,
and yeah, he's a really good guy.
Yes.
Yeah. So you are Cuban American. That's great. So is it true that Cuban Americans is religious? Is part of your religion when you wake up to have a cortadito?
Oh, before we go to sleep and when we wake up, yeah.
Sleep, right.
Yeah.
So why medicine?
So, I kind of took the long way. In undergrad, I did health sciences and exercise physiology. Ended up doing a master's in physical therapy. And I've always had an interest in kind of training and rehab. And for me, I thought that was kind of like a natural career choice. And then about a year into my practice doing orthopedic rehab, I got the itch to do something else. I thought about going into education. I started a PhD program in exercise physiology. And then I just very quickly realized that just wasn't for me. And I just found a call. And I just woke up one morning and said, you know what, I want to be a doctor. And left and went away to medical school and, never looked back.
Right. No, that's great. I'm glad you share that because a lot of people I speak to over the years, when we talk about how you decided for your career, you invested some time before you decided to be for medicine, going for a doctor, right? You spent some time doing the physical therapy.
Yeah, well, so I actually worked for 1 year. I had already had all my requirements because there were very similar requirements for graduate school for physical therapy and medical school. The only thing I was missing was organic chemistry, which I ended up taking in Miami-Dade while I was working in preparation for my application to medical school. Nice. But definitely it was a later in life decision, and I really think it's a calling. I mean, the best description I can give is someone who wakes up one day and says, I want to commit to faith and I want to become a priest. I mean, for me, it was very, very similar to that. I just couldn't find anything else that would, make me feel fulfilled.
Right. That's awesome. So I also understand that you work a lot with residents, right? Can you talk a little bit about that?
Yeah. So, so it's great. Prior to coming, one of the main reasons I wanted to come to Memorial, I wanted to go to Memorial, was the fact that I had always wanted to work with residents and be involved in resident education. So when I saw that the program opened up, and coincidentally there was a position, surgical oncology position, I naturally applied. And I think it's been fantastic. I think having residents keeps you on your toes. It's important to know that you're kind of training the next generation of surgeons. I remember my experience as a general surgery resident, and I have a lot of fond memories of having met so many surgeons and kind of taking the best of each one of them and kind of abandoned the worst of each one of them as well, and kind of created my own persona and my own way of being a physician. But I still look back every day at something that I do, and I can pinpoint who taught me that. So, I wanted to give someone else that kind of experience as well, and hopefully, some of our residents 5-10 years from now will do something and kind of have a small flashback of a comment I made, or maybe even something I did wrong, and they learn from it. Right.
Right. No, that's a good point, and that is true. When we work in a teaching hospital at Memorial, and we have a lot of residents and other areas in healthcare that they're learning. Going back to when you were a resident, do you see a big difference in the way the training was approached or offered compared to now?
Yes, so I have two very completely different perspectives on training. So I started my general surgery at Maimonides Medical Center, where Jeremy trained. And that was a tough program. I mean, tough, like what we call a malignant program. And if you've never heard of what that means, malignant program really means that the program is really, really tough on the residents. I mean, they want to break you down, and it's kind of like what you see in movies and TV shows where, I mean, you're just like a slave. And the idea is that they break you down to then build you back up again. 2 years into that program, I had a soon-to-be chief resident at Beth Israel in New York just call me and say, hey, listen, I remember you as a student. We have a third-year spot opened up here. They asked around if we knew of anybody, and I remembered you, and I just kind of wanted to see where you were at, what you were doing. And I was like, yeah, I'm completely interested. Went, interviewed, got the job, and found that was a totally different world. I mean, completely different. And I still remember, like, one of my first days rounding where, a patient had, like, a perforation, had an abscess, and the plan was to get the radiologist to drain the abscess. This was like 7 o'clock in the morning rounding. Wow. Around 1:30 or 2 o'clock, we go to round again, and it hadn't been done. I blew up. I was like, what do you mean it's not done? You have to drain it. And I remember the attending looking at me saying, hey, it's okay. Patient didn't die. It's all right. It's going to be okay. We'll get it done later. And I remember like having like this moment of like panic, but then also like this surreal, like, what do you, like, he's so calm about this. And then I started, it was such a stark contrast. Like, it was a very gentleman-like program. And then I had to kind of relearn. And I'm so glad I went through that, because I fear what I would have become if I would have stayed in this malignant program where your mentors, exhibit this kind of malignant behavior, and they do a good job. They get the job done, but through that kind of forcefulness. And I kind of, for the last 3 years, I got to learn how to be a kind physician and get things done without that, that malignant attitude. So, which didn't really fit my personality anyways. Right. But you definitely become a product of your environment, a product where you train. It's impossible to say that if you spend 5 years in a place that's beating everybody down, that you're not going to walk away with some of that, right?
Right, that's true.
Yeah.
That's a good point.
Yeah. Now we're very nice. I mean, now, now we're too nice. But no, I mean, I think, our program is very much, when I started, it felt kind of like home, because it really mimicked what I experienced at Bethesda. I think all the attendings are very kind. I think we're approachable. I think our relationship with the residents is nice and gentlemanlike. It's different. It's different. I mean, I think they were a little bit tougher on us overall, but they still get burnt every now and then. I still think they get a taste of what it means to have a kind of a tough boss.
Right. So that's a good point. So then if I happen to run into a surgeon who's a little bit difficult, we would say, I can assume that he came from a LinkedIn program.
Well, yeah, I do think you're a product of your environment, for years and years, training has been like that. If you look at the origins of surgical training, right, one of the first surgical programs was developed by a surgeon who has known history of cocaine abuse, right? And it's this tough love environment has been in the surgical training for years and years and years, and I think it's taking a long time to kind of break that mold. I mean, it used to be that surgical trainings were pyramidal, meaning that you got 10 people to come in, and there was no guarantee if you were going to finish. So you start off with 10, and you knew by the end of the 5th year there were only 4 or 5, what have you, and you were competing for those spots. Right. So it's a different environment. Now when we accept residents into training, I mean, they're guaranteed that they're going to get through as long as they perform. Sure. But it's not pyramidal where you kind of come in and, you need to prove yourself or not, you're going to lose your spot. And, it's a different environment now.
Okay. So that's great. So residents now that are coming up that interact with you, what can you share for any advice or tips if they're getting ready to be in your service?
Yeah, I think it's important to, so my service I think is unique in the sense that we're not a huge volume service. So for example, in any general surgery service, you may do 4 gallbladders in a day, 3 hernias. You may have 25 people on your service because it's a lot of, turnover, right? Our services, surgical oncology, tend to be smaller services, but the patients tend to be much more complex. In general surgery, you might get someone that comes into the emergency room, they have a gallbladder problem, take the gallbladder out, they're home in a couple of days. A lot of the patients we're operating on, we've been working them up for months. We saw them initially when they were diagnosed 4 months ago, so we go through the whole process of educating the patient, teaching them about the disease, formulating the plan, meeting with radiation oncology, medical oncology, and other services. Then we follow them, see that they're doing well with the chemotherapy and stuff. Then we see them again to talk about surgery. Then we operate. Sometimes the operations are very long, very complex, high risk, a lot of morbidity, and then kind of prolonged length of stays, and then follow up. So it's really it can become overwhelming as a resident to come in and have to navigate that long, kind of follow up. The other thing about our service is that we deal with a lot of end of life discussions as well. Sadly, not every patient that we treat gets the outcomes that we want. Sometimes we have patients who I might have operated on years ago, but are now being admitted with recurrent disease, and we're talking about hospice, palliative care, dealing with watching the death of a parent, right? And so emotionally it can be very taxing. So it's not that uncommon that I tell the residents, hey, listen, if at any point it gets kind of heavy, and you're kind of feeling the strain of dealing with this on a day-to-day basis, let me know. We'll talk about it. Maybe you just need a break. I mean, because even I feel it sometimes. I mean, I'm used to it, but there's days where I'm just like, wow, today was what I call hospice rounds, right? I mean, sometimes the service is a very heavy service.
Right. Well, I'm glad you brought that up because I do have a question about that. How do you deal with, telling people, that, there's nothing else that we can do?
Yeah. Yeah, that's an interesting discussion to have. So I feel very privileged to be in the position to do that. I feel like I've learned a lot from my patients. If you're religious, right? I mean, I'm Catholic, and I think the older I get and the more children I have, the more religious I become. And, something that holds true in Catholicism is that we learn through suffering, right? I remember that I was sitting in a course. It's a palliative care course, and there were multiple different physicians, and the topic of the day was suffering. And I remember saying, well, I don't want anybody to suffer, right? And then one of the ICU docs said something that really struck me. And he said, well, again, if you're religious, we learn through suffering. If we eliminate suffering completely, then what lessons are we going to learn, right? So I feel very privileged to be able to learn through my patient's suffering and think, well, what if I was the one in that bed? What if it was my mom? What if it was my dad? What if it was my siblings that were dealing with this, right? So I try to learn from it. Now, emotion, it can get taxing, but I think it's a privileged position to be able to be the one that kind of navigates that. And while it's never feels good, it does feel good when you can help a patient or family members have closure.
Sure.
Oftentimes in those end-of-life discussions, I think, well, this patient has been my patient for years and years, but at end of life, kind of the patient's families, I think, really become my patients. I always give the example of, I lost both my parents to cancer. My dad battled rectal cancer for about 4.5 years before he passed away. My mom died 6 weeks after diagnosis of lung cancer. And, I saw a stark difference in my acceptance of those two losses. My dad having him around for 4.5 years, the day that he passed away was as if it was the first time someone told me he has cancer. I mean, I never stopped to process it. And at this time, I was already my second semester in medical school, so I've got a little bit of an understanding. And I remember not knowing anything, going to the Merck manual as a physical therapist and seeing, like, what does T3N1 rectal cancer mean? And thinking, like, wow, this doesn't look that great. So I knew, but it was never addressed. A physician never came and sat down with the family, myself, and said, listen, this is what's going on with your dad. This is how it can impact your health. This is how it can impact, your children's health if this were to happen to you. This is what this cancer means. This is what the survival typically looks like. Your dad's 4.5 years into it. We have to think about what are we going to do. Those discussions were never had. So, the sense of loss that I had with his death was this emptiness of, like, I wasn't there for him at that final moment. Now, my mom, she was diagnosed. Initially, we were trying to be very aggressive about treatment, but very quickly it was evident she wasn't going to tolerate anything, and she spiraled very quickly. And as a family, we came together. We said, this is really hospice situation. And we sat, we met, we came up with a plan. I basically became her hospice physician. I was at her bedside. The whole family was there. Minutes right before I kind of thought something was going to happen, I came out. I told the family, listen, I'm really worried. I think something's going to happen soon. Maybe we should all come in and say our goodbyes. And it happened that way. And I think that in those 6 weeks, I have such a sense of closure and accomplishment as a child. I feel like I was there for my mom during that moment. Right. And for my dad, I had 4.5 years, and I just couldn't get that closure, and I still don't have it totally. And I know it's because I just didn't have that same level of involvement and stuff. So, these end-of-life discussions, I always think, well, what can I do to help the family members have that same closure that I had? Because, again, I see the stark difference between my experience with my mom, where we were educated and we spoke about it, we planned, versus with my dad, that everything was kind of like, let's not talk about this, and when something happens, it just kind of happened and left someone in limbo.
Wow. Well, thank you for sharing that, and sorry about your parents. That gave you now, though, a different perspective for your day-to-day when you're dealing with patients that, unfortunately, at, like you say, end-of-life treatment. That makes you stronger, right, as a physician and as a son. I want to ask you about your father, because I was told this by a close friend of mine, that you don't really ever feel like you're a man until your father passes. Is that a true statement?
I'll take that a step further. Something I would say that I don't think you ever feel like an adult until you lose both parents. You lose one, but you still have the other one, especially if your dad goes initially. My dad and I had a very close relationship. The relationship with your mom is a little bit different, right? I mean, it's two different things. So, even though you're an adult, and I had, at the time, 3 children already, and you have work and you have stress, and when your mom's over, and she says, hey, do you want something to eat and drink? She makes you that little sandwich the same way she's made it her entire life. And, for a brief moment in time, like, the world pauses and you're a kid. Like, you don't notice it at the moment, but there's something so comforting. And the comfort there is that you're a kid without responsibilities, right? For that brief moment, they take care of you. Right. The moment that one goes and you're alone in the world, I don't care if you're 70, 85, it is the first moment that you realize that you're an adult. You're never going to have that feeling of being a child again. It's very subconscious. It's not like you're there and you're like, oh my God, I'm a kid. But there's this very subconscious feeling of, like, you're home and you're safe. And once both of them are gone, it's, to me, that's like the first time that you're truly an adult and you're alone in this world. Or maybe not alone, but that you're an adult.
Right.
Yeah.
Right. Wow. And so dealing with and experiencing all that, how do you handle stress and burnout?
Well, so, I remember when I first met my wife, she used to get upset and tell me, well, you never get mad about anything, right? So then I go, you don't get mad about anything. And I think as time goes by, she's told me more than once, oh, I get it now, right? Everything is about perspective. And again, like I said, I feel very blessed to have experienced a lot of things that people don't experience early in life through my interactions with patients, right? Which put things in perspective, right? Yeah. So if I'm driving, someone cuts me off, I'm like, I can get mad, but then I got to think, well, what's going on with them, right? I mean, I go, thank God I'm not in the hospital right now. Thank God I don't have cancer. Thank God that my family's alive and isn't sick. Maybe they're rushing to the hospital, so you put things in perspective. Right. Because there's going to come a day, for all of us, where we're going to sit back and we're going to look back and be like, wow, the times were really good. They were really good before, right? I mean, this is bad, but I wish I could appreciate. I mean, there's a, I don't know if you ever watched The Office.
Of course, yes.
Right? So we've seen The Office a billion times. And there was one quote, I forgot the name of the character.
Andy Bernard.
Andy Bernard.
Right?
I'm going to mess up the quote completely,
Right.
but it was something to the extent of, I wish we knew we were in the good old days during the good old days, right?
Right.
And that's what it is, right? So, think about simple things, right? Think about how many times you've been sick and you can't breathe well. And the first thing you think is like, man, I take for granted the fact that I could just breathe normally, right?
Right.
I mean, have you ever been massively constipated, you can't poop, and you're going,
Right now.
So whenever something bad happens, you put things in perspective. Why do you have to let something bad happen for you to put things in perspective? So I'm putting in perspective now because, life's too short for you to dwell on things that are not meaningful.
Right. You and speaking of that, you have partners, right, in your group. Who are your partners?
So Christopher Gannon, who's the chief of surgical oncology, and now we have a new partner, Gabriel Olagun, which very cool. I mean, they're both great partners, but it's cool that Dr. Gannon and Chris trained at MD Anderson. I trained at UNC in Chapel Hill, and Gabe did a research fellowship at MD Anderson, and then his surgical oncology fellowship at UNC. So it's kind of a nice, nice blend. Yeah, but I'm blessed to have a very good group, very supportive group of guys. Yeah.
Right, because that's important, right?
Oh yeah.
In this kind of a service, you want to have a good group of guys.
I mean, you got to have people who are very similar in their practice. I think similar in their temperament, but can also kind of balance themselves out. I mean, I feel really blessed. I think we have a great group. I think Gabe's an excellent, addition to the group. And, hopefully as we keep growing, we keep on bringing in good people and just hopefully providing a better and better service to our patients.
Yeah, no, I met him. We call him Dr. O. Yeah. Dr. O, right. He's a really nice guy, soft-spoken guy, right? Yeah. Really nice guy. Dr. Gann, on the other hand, not so soft-spoken.
It depends when you call him.
No, me and Dr. Gann go way back, and matter of fact, he just has a busy schedule.
Yeah.
Yeah. But going back to surgery, I've done a few cases with you, and we want to talk about the different procedures that you do, which is pretty exciting, and I want to get also your opinion on other procedures that are coming down the pipe. Sure. But no, I just want to emphasize that you're a stand-up guy in the operating room. I have done some surgeries with you, and maybe certain things weren't going right at the time, but you are how would you say that? You're standing by what you preach. You practice what you preach. You always held your composure. You're very nice to everyone. You're very appreciative, you can tell. And more importantly, you can see how much you care about your patients. But let's go into some of the procedures that you do. Let's talk about the HIPEC.
Sure. So HIPEC is basically acronym for hyperthermic intraperitoneal chemotherapy, which is basically a washing machine. Right? We're washing out people's abdomens with heated chemotherapy. Their tumors can spread through different avenues. They can spread through the bloodstream to the liver, to the lung. It can spread to the lymphatics. But oftentimes, they can also shed cells into the abdominal cavity and create what we call carcinomatosis or peritoneal disease. So you can imagine if you were to open someone's belly, take a bunch of little different sized BBs and just kind of toss it in there and they just kind of stick to everything. That's what peritoneal carcinomatosis is like. And while the liver gets great blood supply, the lungs, when we give IV chemotherapy, it doesn't really, the concentration of chemotherapy isn't as high on the surface of the organs. So there's a strategy called cytoreductive surgery where we basically operate, remove all visible disease. So we're trying to leave behind just microscopic disease. And then, patients are basically put through the washing machine where we're washing out the abdomen with 90 minutes with a heated chemotherapy to try to kill off whatever cells are floating around that with time can grow again.
That's great. And what is, if a patient has to endure that, what are some tips that you tell your patients, or what should they expect with that surgery?
Yeah, so, one of the things that I think we do quite well at Memorial, and it's a team effort, is that, we try to prepare the patients for surgery. Dr. Mehta, who's an integrated medicine doctor at Memorial, we work together a lot in a kind of prehab situation where, before surgery, since we usually have months to get them ready, most of these patients are getting chemotherapy for months. So we have a gap where we can improve their nutrition. So we talk to them about exercise, about the impact of diet on survivorship. We look at even emotional and spiritual wellness, right? So the idea is to really, fill up the tank. I always give the example, you can drive a car at 100 miles an hour with a full tank, half a tank, quarter tank, or on fumes, and it's not until the gas runs out that the car stops. So you look at a patient like, well, how much gas do you have in the tank? And how much can we fill that tank in preparation for chemotherapy, in preparation for surgery? So a lot of the preparation is beforehand. And then after surgery, we try to set up realistic expectation that they really understand what we're doing, right? So we tell them, listen, on this day, we're going to start a diet. We need you to get up and walk. We're going to give you blood thinners. We're going to give you breathing exercise, So we kind of set the tone so that they know what the game plan is. We do have what we call enhanced recovery pathways, where it's specific pathways of what fluids anesthesiologist gives, what kind of pain meds do we give, what combination of cocktails we give, things like abdominal wall nerve blocks, a bunch of things that have been shown scientifically to expedite someone's recovery. So it's a kind of a culmination of this preoperative, intraoperative, and postoperative enhanced recovery pathway with multiple things that we do. I'll give you an example of how impactful that can be. That at my last institution, I helped establish some of the enhanced recovery pathways for colorectal surgery, and it was like overnight length of stay went from 5 to 3 days. I mean, surgery stayed the same, everything stayed the same, but the difference was now that you're implementing this recovery pathway that kind of standardizes when we give a diet, what anesthesia is given, all of a sudden patients just tend to do better. So it's a lot of preparation behind the scenes.
Yeah, I can imagine. Yeah. And what is one of their biggest concerns? Some people say scarring. How's my
well, I think patients' first concern is, am I going to die? Right? Like everyone knows has this concern that they're going to get anesthesia and die on the table. That's exceptionally rare, right? Unless you're a trauma that's already coming in and you're going into the OR for like a heroic life. It's uncommon that happens. I always tell patients that the day of surgery is really the day when I'm most at ease, because if something bleeds you, stop it from bleeding. If something, that's under control. Now, once we're done, then it's kind of up to nature and God and spirit and whatever you want to call it. Why some people you do the operation the same exact way, and some people a couple of these are just killing it and are ready to go home, and other people can have a leak, can have a pneumonia, can have everyone's a little bit different. Sure. But I think their first concern is always about, am I going to survive the operation, right? Because they've looked into it and they hear this huge operation, so they're worried about that. Then they weren't like, when am I going to get back to normal, right? When am I going to feel normal? Can I eat if I don't have my stomach, right? If I have an ostomy bag, how long is that going to happen? Am I still going to be able to poop if I have an ostomy bag? I mean, it's a myriad of questions related, specifically related to each operation. But their first concern is, am I going to make it out of the operation itself? And I can tell you, by and large, I mean, it's very rare that something happens the day of. Obviously, it can happen, but that's an uncommon scenario.
Sure. We talked before we started the show. You did have 2 attempts on your life and your journey of going through medicine. Yes. And when you share quickly, briefly, those 2 instances?
Yeah, so I think Elon Musk is out to get me. So, interestingly, I had just purchased a Tesla, and it was around Christmas. And I'm going into Round on the weekend. And, I'm coming in, and I'm trying to get back home, so we're taking the kids to a Christmas event. So I'm driving. And like all of a sudden, a truck is maybe 5 cars in front of me, and a crowbar falls out the back of the truck. And it's like one of those movies. I kind of see it turning,
Right.
hits the ground. I hear this metal clink, and it's coming at me. And I'm thinking it's going to go through the windshield. But all of a sudden, it kind of bends and it punctures the tire. I get a flat. I swerve to the side, but I'm okay. And I'm thinking like, oh my God, like, my children, and someone's going to ask me, well, when did your dad pass away? Oh, it's horrible. It's 4 days before Christmas. He was driving to work, and a crowbar went through the window and stabbed him in the head. I mean, it's like something out of a movie, right? And then like 2 years later, like I'm driving on Palmetto, and I hear a thud. And I don't think anything of it. And later on, when I parked the car, there's like a gunshot wound, a bullet in the back of my car, like right above the right wheel well, and apparently that's something that happened in Palmetto, right? But I mean, it's like I told the cops, they're like, yeah, that happens all the time, right. But just put a report, right. And so I ended up turning. I was like, this is just like bad juju, right? Like,
right.
Like so I do think Elon Musk is probably
going after you.
Yeah.
Well,
I did not buy another Tesla.
You didn't buy another one. Well, I don't know if you're familiar with this. This is called our Wheel of Destiny, and this has some things on there, different subjects and questions and fun things to do. So we're just gonna have you give it a spin, and wherever it lands on, we're gonna do it. Let's see. Operation. Look at that. Of all the things to be, Operation. He picked it. All right. So we have Operation. You do, like you mentioned, you do some very intricate surgical work there.
Well, I can't do anything until we authorize insurance.
That's right. This patient's authorized. This patient consented, and mainly the procedure here is the wishbone. That is the most difficult, and we're just going to ask you to see if you can get the wishbone out.
The wishbone's the most difficult one?
That's the most difficult one.
Let's see.
Or at least that's what we hear.
Let's see if I can pull it. Oh. What did I say? You rarely die in the OR? Is that what I said?
Right. So you really die.
There you
go. Whoa!
It's
look
out.
At that.
It's out.
Wow. Okay. Well, I mean, we don't want to.
7 years of training.
I'm telling you, we don't want to see. We don't want to discuss how many surgeons took forever.
I mean, the truth is, we typically do that with a robot, so that's why I'm a little rusty.
Right, you're a little rusty.
Using my hands.
That was incredible. That was amazing. All right. Well, there you go. He has good hands. Good hands. Surgical hands. All right. Give another spin if you don't mind. We're gonna do a couple more spins. Let's see.
Chat room.
Chat room. All right. Great. So, if for people who missed the last episode, we are doing something different. It's just a beta test right now, so we're not exposing it to everyone out there. But we have a few people that are online in our chat room, and they're able to listen to this episode and just chime in with some questions that they might have at home that maybe I didn't think of to ask. So we're just going to look real quick. A few people here. You see a good question here. RFA. Are you familiar with RFA, radio frequency ablations? And
yeah.
What is your opinion about
that?
Yeah.
So RFA an ablation is a local regional therapy, meaning, a tumor, for example, that's inoperable. And rather than being able to cut it out, you end up burning it or freezing it. You're doing some kind of local treatment to it. So RFA is a radio frequency ablation. It's using radio frequency to burn, quote unquote, burn a tumor. We use it sometimes in patients who have either multiple liver tumors or inoperable tumors, or metastatic disease, someone who isn't a candidate for resection, for an operation to remove it. So we ended up basically burning the tumor. There's different specific indications for different diseases. I think obviously every treatment works in the right patient, right? So it really depends on what the disease is, what the distribution is. But it is one of the tools in our wheelhouse that we use for patients, mostly who have liver tumors that for whatever reason can't be resected or cut out, and we end up burning with some form of, technology, whether that's microwave ablation, RFA ablation, cryoablation, nanoknife ablation. There's different types of ablative tools, which all work very well.
Okay, great. Now, one funny one. Is it true that you are a famous breakdancer from the Bronx?
No, that's not true. No, it's from Washington Heights.
Washington Heights, right. All right, let's give it one more spin if you don't mind. I'll hold this here. There we go. Travel. Okay. So travel. Do you travel, and if you do, where do you like to go?
We try to travel. We're taking a trip soon to Paris with the kids for my daughter's 10th birthday.
Nice.
Whenever we can, we try to get out. I really want to try to go to Machu Picchu. I know my dad always wanted to go to Machu Picchu, so I think kind of have always stuck in the back of my head of a place that I'd like to go. Where else? Went to Colombia recently.
Oh, nice.
With my wife. Yeah, she would not let me go alone. Where else?
Did you have some aguardiente?
Yeah. We love. I mean,
Right?
Colombia was beautiful. I mean, just the food was fantastic. I mean, it really makes you rethink the quality of food in the U.S. versus outside of the U.S. But that's a whole different podcast.
Right. What's the dish? I always say around bandeja paisa.
Plato paisa.
Something like that, right?
It's basically a plate with a lot of food, right? It's got like some kind of plantain.
Everything.
I mean, like a fried pork rind. I mean, but you know what was amazing is I remember we get there, and my wife and I were both pretty health conscious. We're healthy eaters, but we're foodies. And, whenever we travel, we always make plans of where we're going to eat because we want to try, this restaurant, that restaurant. But by the end of the trip, we're like, I can't wait to get home and just have home cooked food, right? That doesn't make me feel swollen and
right.
And there we were like, my God, I feel so good. It's like I think I've lost. And meanwhile, we're eating huge breakfast, huge lunch, huge dinner, snacks in between.
Right.
You know what I mean? But the food is so natural. I mean, we went to one place, we went horseback riding. And I swear when we got there were 2 chickens, right? And when you come back, we have a snack for you. And those 2 chickens were not there anymore, right? And we ate chicken. So I have to assume, I'm assuming the worst for the poor chickens. Right. But, it was incredible. Like, as soon as we got back, and we were like, oh, man, we're heavy again. So yeah, I mean, Colombia was really great. And a fun fact, like my parents are Cuban, but my grandfather, my dad's dad, was Colombian, who emigrated to Cuba when he was like 9 years old or 10 years old. So it was nice to kind of get there and kind of get a sense of where my heritage was and stuff. Yeah. So it was nice. It was a nice trip.
And so where were you going around? Where exactly?
We went to Medellin, and then we went to Eje Cafetero, which is like where all the coffee production is and stuff. That was really cool. Yeah,
that was nice. And it's affordable, right?
Yeah,
very affordable. Yeah. All right, so now we're going to go back to some serious stuff. Let's go. So somebody that might be interested in medicine that watch these students, what can you give us just a typical day to day for you? What would be a day coming into, whether it's a surgical day or an office day?
Yeah, so those 2 days are different, obviously. I mean, so every day we have to come into the hospital and round on whoever's in the hospital, whether that's preoperative patients or post-op patients or consultations regarding different patients with different tumors that are admitted to the hospital. After rounds, we either go to the office where we're seeing patients in consultation or in follow-up. So patients are coming to see us who have just been newly diagnosed and they're referred to me to discuss, their surgical treatment, or patients who we've operated on who are coming in as a follow-up, like right after surgery, or even follow-ups, patients had surgery years ago that we're monitoring them. OR days are different. OR days after rounds, and we go to the operating room and we just we do our cases, and in between cases we'll round again or see new consults, and we'll be there until we're done with the cases. Everyone's scheduled a little bit differently. It schedules those things a little differently, but in general, as a surgeon, that's what you're doing. You're splitting your time between the operating room, the office, and seeing inpatients. And then I have some time where I have dedicated research time where we work on research and stuff.
Nice.
Or resident education related items.
And speaking on surgery, how important does an anesthesiologist play in your surgical cases?
Knowing that specific case. So, for example, when I started, we started doing the high PEC cases, and unless the anesthesiologist had experience in that in another hospital and training, I can't expect them to have an understanding of what's going on, right? Like, we're operating for 8 hours and we're doing 90 minutes of chemotherapy, and what do you mean we're cooling them off instead of heat? There's a lot of so we met and we go over our ERAS. We have an anesthesia protocol of how much fluids to give, what pain meds, when to cool the patient off, what to look for. So one is having that knowledge base, and either that they had it directly or we speak about it and we kind of come to that conclusion together. And then the second part is really good communication, like it's not that uncommon. I'll just kind of randomly say, hey, is everything good up there, right? I mean, just so that we're still on the same page, or I'll tell them, hey, if something comes up, I promise I'm going to let you know before we get into trouble so that you have to catch up. So I think one is knowledge base, right? And we can't assume that people have experience in a certain case, especially if it's something that's very niche. And then the other stuff is just very good communication skills.
Very good. And let's go around for the rest of the surgical team. So how important is it to you to have a knowledgeable surgical tech?
Oh, same thing. I mean, I think after we work with the same surgical tech over and over again, I mean, they kind of automatically know what instruments we want, what to get. They'll oftentimes be the ones telling the circulator nurse, like, hey, he needs this suture before I can even ask for it.
Right.
It's all about flow. It's like a dance, right? It's a team. And when you have new team members, you can get through it, but it's not as smooth, right? So, I think everyone in that room plays a huge role. Whenever you have someone that's new and doesn't know the flow of the room, it takes a while before things are not to say that things don't go well, but it's not as smooth, right?
Right.
And I think it's kind of pleasurable for everyone when you're kind of on autopilot, right? It's kind of like when you have that person on your team that you played basketball with. I remember in high school, I wasn't, even though I'm like 5'7", I was still on the basketball team. And, we used to play all the time. I mean, we would spend the entire summer playing and playing and playing, going to this gym and going to that gym. By the time the season came around, we've been playing together hours and hours every day. Like, you knew everybody's, position, where they were going to go, their failures. It just became an automatic. You bring a new member into the team and it's like, oh, we don't know, where you're at, so it's the same thing. I think the more you play together, the smoother things go.
Sure.
And I think you have to be very patient during that process where you're learning to make sure that, you give someone a chance to catch up. If you're a new scrub tech, you don't know how you do things. And then, to be fair, 10 different surgeons are doing it different ways, and you got to keep track of how to do it for each one, right?
Right. That's a big one. Yeah, and I think a lot of surgeons don't take that into account, when you're working with someone, whether it's a tech or a nurse or an assistant for that matter.
I think, sometimes surgeons get a little bit of a bad rap because, they may say, well, this guy got angry, but, the stress, the innate stress related to that operation, you do it every day and you kind of become comfortable and you don't really show it, right? And to a certain extent, you might not feel it completely because if you did, you can't work, right? You have to have a calm mind. Right. But in your mind, you're always thinking, what could potentially happen that's bad, right? And you're writing that fine line of doing what you need to do, but also fending off the hard complication. And when things aren't, for lack of a better word, perfect, it really throws you off. It throws you off, and I can understand why every now and then you have this little emotional panic inside, right? Because you've been holding the stress in, unknown to everybody, and then something that's key happened. It's like, and you kind of, and it's not to justify it, but I can understand where that comes from. How these little bursts of anger or frustration comes out because you've been dealing with something subconsciously for a while, knowing that it could happen. All of a sudden it happens, and now you don't have what you need, and it's a stressful situation. Again, it's not to be forgiving to what you can't do, but I understand where that happens sometimes. I try to avoid that as much as I can, only because I think you're the kind of you're the captain of the ship, and if you panic, then everyone's going to panic.
Everyone else, if you start losing it.
And you start realizing strategies and how to manage it. Interestingly, I said that as time goes by, I kind of feel like I've become closer to God, and you just kind of like. My go-to now, and I would have never thought this years ago, if I'm in the UR and something's really stressing me and I'm like, oh my God, I'm worried, I start praying. Like, I literally start praying under my breath, and I just feel like my heart rate slows down, I calm down, and it's what works for me. You know what I mean? It's just I kind of center myself just with a little prayer internally, and somehow, man, that gets the nerves off, the shakes off, and you can kind of focus on. And I think everybody's got their go-to to try to clear their mind at a moment where, if you lose it, it's going to be a bad situation. Right.
Because then how can you critically think, make decisions? I think everyone handles bleeding differently.
Oh,
that's right.
I hate bleeding. Right. I joke around, but, we do cases with the vascular surgeons, and I'm just like, blood's coming up. Like, like what? Yeah, so, we'll resect the tumor, and we're like, oh, there's vascular involvement, and the vascular surgeon's like, doing their part, so I'm waiting, watching, and they cut in the blood, and I'm like, oh my God. Like, I can't, because for us, for me, what's bleeding? For me, bleeding is surgical failure, right? Like, my patient is
sure.
bleeding. For them, it's like, this is a necessary part of the case. Like, they're going to bleed, but I'm just like, oh, Lord, thank
We're
God.
flushing the arteries.
Yeah. I do not, I clearly was not built for vascular surgery.
Right. No, that's good. Yeah, no, definitely people handle stress differently, and it's not to condone behavior of people that explode, but we're human. We're not perfect, and you're right, and especially in your specialty. I mean, it's very critical, high stress, surgery. That there's a patient on the table. That's somebody's family member that are waiting for them outside.
Yeah. Well, I mean, if you think about it, patients oftentimes ask, well, how big is this operation? And, in my mind, I have this spectrum of like, what's a big operation, right?
Right.
And what's a small operation relative to what we do on a day-to-day basis, right?
Sure.
But the truth is that even if it's a quote-unquote technically simple operation, it's a big operation for the patient, right? I mean, think about how vulnerable you are. I mean, it's like rape if you really think about it, except that you're consented, right? The patient is drugged, being kept alive artificially with someone who they're relying is going to do the breathing for them and keep them sedated, right?
Right.
And then you're cutting them open and you're kind of massaging these organs. I mean, it's I'll never become numb to what it is that we do. So imagine putting your life in someone's hands like that. I mean, at a point that you can't even get up and run away, right? And then when patients tell you, well, am I going to wake up in the middle of surgery? You're like, oh, of course that doesn't happen. But man, I mean, if you think about it, right? I mean, what if the anesthesiologist, like, I don't know, something. I mean, you're putting a lot of trust in your doctors,
right?
When you have an operation,
right?
No, I heard
it was like that with the anesthesia, right? Where, like, the patient could feel everything, but they couldn't move.
Right. And again, I mean, I don't think any of it, but thinking very practically as a non-clinician, like, I mean, imagine we're saying we're putting you to sleep, we're paralyzing you, we're putting a tube to breathe through you. Someone's going to do the breathing for you, and they're going to be titrating medications, like, to make sure that you're comfortable enough, whatever, but that you're not dying, but that you're alive. And then he's going to cut you open, and that's going to stress your body out, and it's going to spike, and we're going to control it by bringing it down, and then we close, and, it's amazing. And then not only that, talking about cars earlier, like if you go to your car and you pull out a spark plug, it's not working, right? I mean, you're done, right? But our bodies have been designed to survive, right? Even emotionally, like we're built to survive, right? So if you think physically, you can go in, you could take out someone's stomach, this, that, you cut things and you sew them together, and for better or worse, things start working, right?
Right.
You can survive without a stomach, you can survive with part of your colon out, or all your colon out, you can take your gallbladder out. I mean, I'm assuming they're all pretty necessary parts, right? Someone put them in there. There's a reason for it, right? Even your appendix, there's a reason for it. But we can take all these things out, and people can have a relatively normal life, even though you did these modifications, right? And then emotionally, like, we're meant to survive. Like, I have 3 daughters, and if they're sick, for me to get them to take Tylenol, Robitussin, it's like a fight. My 11-year-old the other day, she's old enough now, we can give her like a Tylenol tablet, and if you would have seen the fuss of trying to get her to swallow, I mean, it was nuts, But then you get a 5-year-old with some kind of leukemia, lymphoma, who's got to get chemotherapy for a year, and they do it, and they live, and they have a normal childhood. I mean, there's something in our brains that when you need to survive, this instinct kicks in, and you flip that switch, and you can, and like I said, we're designed to survive physically, mentally, and spiritually. I guarantee, because there's no way that we can get through what we get through and do unless that was the plan, right?
Yeah, no, absolutely.
Or the design.
Yeah. Or the design, yeah. And you mentioned robotics earlier. So what do you see the future of technology and robotic surgery for your specialty?
Oh, I mean, for us, it's been huge. I mean, I can tell you that, I finished my training in 2000. Well, so I started my general surgery in 2004. Then I did I finished my fellowship from 2009 to 11. And let me see, how many robotic cases did I do during that time? Zero, absolutely none. And then as an attending is where I picked up on the robot, and I was very fortunate enough that my the first group that I joined ran a minimally invasive robotic fellowship, and they were great teachers, and they helped me really speed up my learning. And now a huge part of my practice is robotics, and I think that holds true for a lot of surgical oncology general surgeons who, I mean, it's a huge part. And what's been amazing about it is that it's really allowed us to perform really complex operations, which before we would have to do open, or if you're going to do it laparoscopically, they were exceptionally challenging with this huge learning curve of, oh my God, I had to do 150 to be able to, get to the point where you're doing it. The robot really facilitates being able to perform really complex operations in a minimally invasive fashion, right? And that's been a game changer. So, it's not uncommon that if we have some, simpler liver resections, for example, that typically someone will be in hospital 3-4 days, they go home within 24 hours because now you don't have this huge incision. And there's a bunch of other examples where by doing the case minimally invasive and robotically, it just expedites patients' recovery. And I think with time it's going to grow. I mean, technology is changing. Now they're working on interfaces so that you can actually upload imaging into the robot. So you can, you might be able to do a liver resection and you can click on a toggle on a switch and the CAT scan or MRI will show up superimposed on the actual liver. There's a bunch of stuff that's coming along that's helping us become better surgeons. Yeah.
Right. And now, AI is a big word. Do you use any AI technology?
Yeah. So I use a lot of AI for research, just for searching things, sometimes helping me with some grammatical stuff. Sometimes when I get writer's block and trying to piece things together, I might throw down a whole bunch of ideas kind of randomly and see what it kind of pops up with. So yeah, it's really an interesting tool.
So now you say you have 3 daughters. Do you want them to go into medicine?
You know what? I can't say no. I mean, I'd say yes. Whenever I see that, someone whose parents were physicians went into medicine, my first instinct is to think that the parents did something right. I think it's a very demanding career where oftentimes for you to do good for someone else, you do bad on your family. And that's why you hear so much about physicians and divorce rates and my dad was never there for me and, and my mom, So, when I hear that children whose parents were, I think, man, they did something right. They must have, really balanced work and home well enough where their children weren't turned off by medicine, right?
Sure.
They didn't grow up saying, well, I don't want to be like my dad. I want to be, or I don't. So, we've devised, I've been very purposeful in kind of trying to, over time, set up a schedule that kind of works for the family. My wife and I, for example, on the phone have a family calendar between myself, my in-laws, her, that has every family event, so I can kind of plan and be like, my daughter has a show at this time, so I can kind of calculate and try to be there. Yeah. So it takes work. It takes a lot of work. But again, I think if they come out of this having a dad who was a surgeon early in my career, I was on call all the time, ER, this, that. If they're able to see all that and want to go into medicine, then I would think that at least I did a decent job at, at being a dad and a physician.
Sure.
My daughters watch Dr. Pimple Popper. Right? So they've come up to me now like, well, I think I want to be a dermatologist, right? And I'm like, oh, yeah, that's kind of cool. I'm like, oh my gosh, the 3 of them. I'm already picturing, the Lagunas and the 3 of them working and doing Botox. I don't know. And but one of them comes up to me and says, Dad, if I'm a dermatologist, do I also get to treat cancer patients? And oh my God, like my heart just melted, right?
Sure.
And I'm like, yes, but the money's in Botox.
right.
No, but just all kidding aside. It was very heartwarming to to have them kind of talk about it, but then also kind of interject that, so I think, man, maybe I'm doing something right, maybe something's getting through to them. Should be a nice thing.
Yeah, because taking a step back, how many years were you in school?
Oh, man.
With all the training and everything.
So, I did my undergrad in 3. I did my master's of physical therapy in 2. Medical school was 4. Then residency was 5. And then fellowship another 2. So
that's 16, right?
Yeah, something.
So 16. So it's almost 20 years, right? A little give or take, right? Because some specialties are longer. Yeah. Did you know that going in, it was going to take that many years?
I didn't do the math.
Right, you didn't. Right, you just kept going.
Yeah.
Right? What's next?
Yeah, I didn't do it.
For this.
The one thing I did learn through that journey was that we're always focused. We're very hyper-vigilant and focused about what the next step is, right? So, first day of undergrad, oh man, I can't wait to be done and be in graduate school. First day of graduate school, man, I can't wait to do my working, right? And I remember my first day in medical school. I hadn't even sat. My ID was still warm because they had printed it out.
Right.
And I'm like, I can't wait to be an intern, right? And
Right.
when you're an intern, so you keep on. At some point, you realize you gotta stop delaying gratification, right? When you live for what I'm gonna be in a year, 5 years, you miss out on the present, right? So
Sure.
if there's any one
Right.
piece of advice I tell students and anyone who's in a career, especially like ours, that we can really mark them. We're like, we're gonna be here in 3 years, in 4 years. This happens. If stop thinking about where am I gonna be in X amount of years. Like, enjoy your time now. Do what you got to do now. Savor the moment, wait for it, but don't make that be your main focus, because I think for a lot of us in medicine, it was very much like that. We're always thinking about what's our next step. We're always working towards that next step, and that's good. It gets you there,
Right,
but
right.
it makes you miss out on the present sometimes.
Right. So basically, be in the moment.
Yeah, be in the
Right.
moment. Yeah.
That's good. That's good advice. How do you deal when surgical outcomes do not go the way you want them to go?
Yeah, so, my first instinct is to really blame myself. Like I said earlier, what we do is very invasive. And, if you're the one who physically operated on the patient, you're the one who cut the patient, put the ball together, did whatever, first thing you got to think about is, like, this is on me. Like, this is what I did. And then at that moment, you start, at least I start to analyze every little step of the case. Like, I just have like a replay in my mind of every little step. But did I do this? Did I do that? Was I happy with that suture? Was I happy with? And it's funny. I mean, it's really in your brain. It's really like playing a video, and you kind of jump cut to the critical parts of the case. And on a rare occasion, you figure it out that it was something you. Most of the time, you look at it and you're like, man, if I really want to be honest with myself, it's unlikely if I had done anything different that it would be different, right? And then from there, I go to my stats. I think that, I like to think of our surgical outcomes like if you're an athlete, right? Athletes keep track of like their, if you're a basketball player, your 3-point, shot average and, assists, whatever. So, all of my major cases, like my robotic cases, any kind of high-tech cases, those cases are very kind of specific to me, pancreas cases, I keep a database. And I can look back and be like, my God, I had this problem. Well, let me look back and see statistically, where am I? I'm beating myself up, but when I look back, I go, well, nationwide, this complication rate is, 5%, and I'm at 2.
Right.
It's not to say that I'm happy with it, but
Right.
at least I'm like, well, so you have to kind of talk yourself off of the ledge, right? So the ledge is like, it was me, and then you have to have this reflection on the case, what you did, what you could have done better, and then look back on your historical cases and see, where, and then we have things like M&M, right, where we kind of present it and everyone reviews it and everyone gives opinions. And again, most of the time, thankfully, you look back and you're like, this happened because it could have happened to anybody, But I do think it's important for you to have that reflective process. I think that you can't become numb and just think, well, this happens because it's a statistic and it could have happened. And there's physicians are like that who just kind of the first thing to think is, blame everything externally. Well, this patient, they're diabetic. Of course this is going to happen. Or, I can't believe that they lifted something heavy and this,
Right.
You got to really look, be introspective and try to figure out, again, try to talk yourself off the ledge and figure out a way to convince yourself that it wasn't you.
Right.
Yeah.
Right. Well, thank you for sharing that. And now, and through your whole career,
Well, and if it was, you accept it, right?
Right,
And
just
and
accept
learn
it.
for that and be like, well, this was my fault, and that's a tough decision. That moment of going to a patient saying, listen, I'm really sad about that this happened, and I apologize. This is really on me, and I've had to do that on occasion. And it is, it's tough. If you ever want to feel anxious as a surgeon, go up to talk to a patient and have to admit that you made a mistake.
Right.
It's tough. I find that patients take it pretty well. I think they feel comforted that you're able to, but it's difficult.
I could imagine. I could imagine.
Yeah.
Now, how important is having a mentor through all of this, your journey?
I think it's huge. I specifically have several people along my training path that I look back and I can definitely feel that I've tried to mold myself based on my experiences with them, whether it's something technical or oftentimes very more of a human touch type of scenario. At the end of the day, I kind of thought to myself, subconsciously, like, what kind of person do I want to be? What kind of physician do I want to be? And then I look back at my experience with other clinicians and I go, I really like the way that he handled this, or I really like the way that she said this to this patient. And you kind of, you make it your own and you become your own person, but really you're a melting pot of all these experiences and all these physicians that you've worked with.
Diet. How important is patient's diet?
That's a loaded question. That's a big question. Yeah, so a common question I get is, well, doc, do I have to change? Can I eat anything I want? And so, well, the short answer is yes. You can eat whatever you want. There's no specific diet for this operation, but the truth is you probably shouldn't eat that way, right? If you go online, there's all these diet gurus that recommend this, that, and the field is so plagued with charlatans and with with misinformation. Diets are very difficult to study, right? You've got to take, and they've tried it. You've got to take hundreds of thousands of people, ask them to eat a certain way, track them, hope that they're compliant, that they're telling you the truth, to then kind of look back retrospectively and see, it's difficult. My perspective is that I think diet is fairly easy. I think that one, you should try to avoid processed foods, right? I mean, anything that has a bunch of chemicals, for the most part. I mean, having a can of Diet Coke, is that going to kill you? No, right? But trying to eat as basic as possible, avoiding processed foods. I'm very sugar averse. I mean, I think sugar overall just isn't good for you. And I think if you don't monitor the amount of sugar that you're eating, you'd be surprised at how much you have. For example, you can go buy bacon, right? And if you get cured bacon, there's more sugar in that bacon than in candy sometimes. So you're telling your kid not to eat candy, but you're eating cured bacon. So I think if you focus your diet on proteins, right, mixing proteins, whether it be steak, fish, chicken, and having a variety of that, and you're getting a lot of protein. Now, you tell patients at least 1 gram per body weight. So, a lot of protein, focusing on that. And then if the rest is vegetables for the most part, right, I mean, that's probably going to take care of 85, 90% of your problems, right? You're eating quality, meats or proteins, and you're eating non-processed foods and vegetables. And then you can get into the nitty-gritty about, well, if you eat fruit, what fruits, right? Are you going to eat berries that are less, have a lower glycemic index than an orange, for example? I mean, that's already, you're kind of getting very specific on things. But I think if you really boil it down to, like, you focus on your main portion meal being a nice, clean piece of protein, and then the rest is some kind of vegetable. And if you want to go beyond that and say, on your starches, you want to pick something that is maybe lower glycemic, like picking a sweet potato over a regular potato, those things, I mean, that's going to take care of 90% of people's, diet issues. I mean,
So you're definitely not a fan of Beyond Meat.
No,
You're not a vegan.
No, I'm not. I'm not a vegan, but again, I don't think there's anything wrong with vegans. I think it's the way that you approach it, and a lot of this has been so commercialized, right? Oftentimes they talk about diets, and it's like the religion of a diet, right? Whenever anyone says that this is the only way that you should do something, because it's not. So, for example, there's a lot of data supporting vegan types of diets, right? The one issue I found, and again, I'm not a nutritionist, but I enjoy reading about diets, is that, and I'll say apparently, is that the bioavailability of some vegan proteins are lower than meats. So it may change the total amount of proteins that you need to take in to have an equivalent process, right? So and there is a way of calculating that. Like, if you look at the labels, it'll tell you, like the daily recommended carbohydrates, whatever it tells you daily recommended protein on there.
Yeah, right. That's true. Right, it doesn't.
And the issue with that is just that, it's hard to calculate that out. Like, the bioavailability of different proteins are different. So it may be that a vegan diet is just as good as a non-vegan diet, but in order for you to get the amount of protein you need to increase the amount of certain things that you eat. So I think every diet, most ways of eating will work if they're healthy, if they're healthy foods and they're non-processed and stuff. It's just a matter of, can you stick to it or not, right? Is it going to be reliable? And that's where I think the difficult part is, and people just don't want to, put in the work, right? I mean, look, the only things we can do for ourselves is what we put in our mouth and how often we move our body and how we move it, right? And I think if we do a good job at exercising and diet, I think that takes care of a bunch of health issues that we're faced with.
Yeah. So there you go, America. You heard it. Diet, exercise, watch what you eat,
and prayer.
And prayer. And lastly, what do you want your legacy to be when you look back? to leave behind?
Yeah, I think I want to have my children grow into kind humans that somehow, make the world a better place in their own way, however that is, whether they want to be gymnasts or doctors or teachers. But, I hope that when they're my age, they can look back and kind of feel that that we put them on the right track and that, their success, is my success.
Sure. Yeah, absolutely. That's beautiful. Yeah. Well, there you go. That was the podcast. We do appreciate you guys tuning in, and we hope you watch more of our episodes. You can find us on YouTube, Facebook, Instagram, Spotify, iTunes, and probably a couple more that I can't think of right now. But our website's coming out next year. We're excited, and that'll be our central hub where you can, find out more about us and the podcast and how to get involved. Thank you so much for your time on the podcast.
Thank you for having me. It's fun.
We do appreciate it. This was Dr. Omar Llaguna, and I'm Stephen Prano, your host. This was a Cyber Health Podcast, and we'll see you in the next episode.